All right, welcome everyone to this Clinical Explainer. I am so thrilled to have you all here. Today, we're focusing squarely on what you, as postgraduate medical trainees and future attending physicians, are going to be doing literally every single day on the wards and in the clinic, mastering high-yield gestational dating and fetal biometry. Look, the reality is, almost all of your diagnostic and management decisions during a pregnancy are going to be heavily influenced by how accurately you estimate fetal age. If your dating is off, even just a bit, your management of preterm labor, growth restriction, and post-term inductions is completely compromised. Okay, let's dive into this and build a rock-solid foundation for your sonographic and clinical practice. So here is our clinical pathway for today. We'll be moving through 1. Clinical dating and terminology, 2. First-trimester sonographic assessment, 3. Advanced later trimester biometry, 4. Navigating special clinical scenarios, and finally, 5. Sonographic fetal weight estimation.
Let's kick things off with Section 1, Clinical Dating and Terminology.
Now, when you're doing your reading or consulting with subspecialists, you might hear different age definitions tossed around. But as clinicians, we have to be incredibly precise. We rely strictly on gestational age. That's the time since the first day of the last menstrual period, or LMP. You might hear embryologists or dysmorphologists talk about embryonic age or post-conception age. That's the time since actual conception, which is exactly 14 days less than the gestational age in a standard 28-day cycle. But remember, for your clinical charting and your patient counseling, you must always use gestational age.
And that brings us to this absolutely crucial number, 280. Your patient's estimated date of delivery, the EDD, is calculated as exactly 280 days from the onset of her LMP, or if you're counting from conception, 266 days. However, when you're actually sitting down face-to-face and counseling your patients in the clinic, it is so vital to manage their expectations with empathy. You've got to remind them that a mere 4% of patients actually give birth on their exact EDD. That's just due to the natural biological variations in fetal maturation and the timing of spontaneous labor.
So how are we calculating that date in modern practice? Well, you've probably seen older attendings spinning those plastic mechanical gestational wheels in their white coats. Honestly, it's time to retire them. Studies show these mechanical wheels are highly prone to discrepancy. Sometimes wheels from the exact same manufacturer don't even agree with each other, and they completely fail to account for leap years. It's a bit of a mess. This is exactly why we have to transition entirely to verified electronic apps or calculators, like the ones built into UpToDate. But a quick warning here, even apps can be flawed. Make sure you're using a validated tool like the free EDD calculator app provided by ACOG.
Moving right along to Section 2, First-Trimester Sonographic Assessment.
As residents, you absolutely need to have this early developmental timeline burned into your memory. At 4.5 to 5 weeks, using the transvaginal scan, you're going to see the gestational sac. By 5 weeks, the yolk sac appears. This is a massive milestone because seeing a yolk sac definitively confirms an intrauterine pregnancy. Between 5.5 and 6 weeks, you should start detecting cardiac activity. But guys, here is an incredibly important diagnostic threshold for your daily practice. To confidently diagnose an early pregnancy loss, you have to rely on strict criteria. If the mean sac diameter reaches 25 millimeters and you still do not see a yolk sac or an embryo, that definitively confirms a pregnancy loss. Once you can actually measure the embryo, which is usually between 6 and 7 weeks, the Crown-Rump Length, or CRL, becomes your absolute best friend. If the CRL is taken at less than or equal to 8 weeks and 6 days, it is quite literally the most accurate biometric parameter we have for pregnancy dating. It carries a tiny margin of error of just plus or minus 5 days. Now keep in mind, this accuracy does slip just a bit to a margin of error of plus or minus 7 days if you measure it between 9 and 13 weeks. But that first measurement establishes the final EDD, and you do not change it later. Stick to it. Let's talk about the actual execution of the CRL. By definition, it's the longest straight-line distance from the outer margin of the cephalic pole all the way to the rump. Clinical standard practice requires you to take the mean of 3 separate measurements. Why are we so obsessive about this? Well, think about it. As little as a 2 millimeter error in your cursor placement can shift subsequent growth percentiles by up to 10% later on in the pregnancy. You could accidentally misclassify a perfectly normal fetus as growth restricted simply because your hand slipped 2 millimeters on an early scan. No pressure, right?
All right, jumping into Section 3, Advanced Later Trimester Biometry.
Once we cross that 14-week mark, our whole goal shifts from dating the pregnancy to assessing interval fetal growth using 4 standard parameters. Let's meticulously review the cranial measurements first. To measure the biparietal diameter, the BPD, and the head circumference, the HC, you first have to locate the standard plane. It needs to smoothly intersect both the third ventricle and the thalami. When measuring the BPD, your cursor placement is super specific. Place the first cursor on the outer edge of the proximal skull, and the second cursor on the inner edge of the distal skull. For the head circumference, though, you place the cursors on the outer margins of the calvarium bilaterally, but you must be so careful to avoid including the skin overlying the scalp, or you're going to falsely inflate those numbers.
But you also have to know when to completely abandon the BPD. The BPD is highly subject to error if the fetal head is compressed, which honestly happens all the time in breech presentations, oligohydramnios, or when the membranes have ruptured. We use a little something called the cephalic index to check this. If the head shape is abnormal, meaning you have dolichocephaly or brachycephaly, where the cephalic index falls outside that normal range of 74 to 83, the BPD is basically useless. In those cases, actually scratch the BPD entirely. You must rely on the head circumference, which holds up so much better against those shape variations.
Okay, down to the body. The abdominal circumference, or AC, is arguably the trickiest to nail down accurately because the abdomen is just asymmetrical and constantly changes with fetal movement. Your landmark here is the point of union of the right and left portal veins, which has this very distinct hockey stick appearance. Make sure you place your cursors right on the skin edge, not the rib cage. For the femur length, or FL, you measure the femur closest to the transducer, the upside femur. Your calipers have to be placed precisely at the junction of the bone and cartilage. You are measuring only the ossified bone. Including the non-ossified cartilage is a classic rookie mistake that will absolutely overestimate the gestational age.
Now, every now and then, you're going to have a patient come in late in the third trimester with zero prenatal care and no prior ultrasounds. It happens. While we can't use these for exact biometric mathematical calculations, there are some really helpful non-biometric skeletal milestones you can look for to help estimate fetal maturity. For instance, the femoral epiphyseal ossification center usually becomes well visualized right around 32 weeks, and the proximal tibial ossification center by 35 weeks. Seeing the proximal humeral epiphyses suggests we are safely in the late third trimester, which, by the way, correlates really nicely with fetal lung maturity. Section 4. Navigating special clinical scenarios. Now, what's really interesting about this next part is how we adjust for specific, complex clinical pathways.
Because, let's face it, biology doesn't always play by our textbook rules. For pregnancies conceived through assisted reproductive technology, or ART, we do not rely on standard LMP ultrasound dating. Since we know the exact date of conception, we calculate the EDD purely mathematically. If it's a fresh IVF cycle, you just add 266 days to the date of egg retrieval. If a frozen cleavage stage day 3 embryo is transferred, you add 263 days to the transfer date. That accounts for the 3 days of lab culture. And for a day 5 frozen blastocyst, you just add 261 days. Simple as that.
This leads us to one of the biggest diagnostic headaches you'll face on the floor, the suboptimally dated pregnancy. ACOG clearly defines this as any pregnancy lacking an ultrasound examination before 22 weeks and 0 days of gestation. When a patient presents at, say, 26 weeks for her very first scan, and the fetus is measuring small, you face a huge problem. Is the fetus actually growth restricted, or is the pregnancy just misdated and simply younger than expected? A single, solitary late ultrasound just can't answer that question for you. So what's the game plan when your data totally conflicts? Here are your hard and fast clinical rules. If you're dating twins and their measurements conflict, the general consensus is to base the EDD on the larger twin. If you have a single biometric marker totally throwing off your averages, like an abdominal circumference distorted by gastroschisis, for example, you simply omit that anomalous marker from the overall calculation. For those suboptimally dated pregnancies we just talked about, the protocol is to rely on serial scans spaced 3 to 4 weeks apart to assess the interval growth trajectory. It's all about the trend.
And finally, Section 5, sonographic fetal weight estimation.
Keep in mind, estimating fetal weight really only becomes clinically relevant and useful for us after about 24 weeks of gestation. Now, there are literally over 30 different formulas out there for calculating estimated fetal weight. However, the modified Hadlock formula is the absolute gold standard and the preferred method over alternatives like Intergrowth 21. The Hadlock formula utilizes all 4 standard parameters we discussed: head circumference, BPD, abdominal circumference, and femur length. We love it because it has a consistently small mean absolute percentage error and is highly reproducible from one operator to the next.
But guys, as physicians, we have to be incredibly sober about the limits of our technology. I mean, take a really close look at this data. In singleton fetuses, our estimated fetal weight is only within plus or minus 10% of the actual birth weight about 62% of the time. That's it. And when you're scanning twins, the accuracy drops significantly due to technical difficulties and crowding. You're only hitting that 10% margin half the time. You absolutely must keep this random error in mind when you're making those really hard calls about early deliveries.
Plus, our formulas tend to struggle right at the extremes where we actually need them the most. Small fetuses under 1,000 grams are frequently overestimated, which can give us a totally false sense of security. Conversely, large fetuses over the 90th percentile are often underestimated. In fact, if you use Hadlock to predict macrosomia, the likelihood ratio for a positive test is only 5.7. Not great. Lastly, while you must exclude distorted anatomy, like a hydrocephalic head, from your formulas, there's one major exception you need to know. If the fetal abdomen is enlarged due to ascites, you must still include that in the abdominal circumference measurement, because that fluid represents a true physical contribution to the overall fetal weight.
Well, we have covered a tremendous amount of ground today, from those very first early embryonic dates all the way up to third trimester weight extremes. But I want to leave you with a thought as you head back to the clinics. Knowing that a mere 2 mm error in your first trimester crown-rump length can shift your patient's growth percentiles by up to 10% months later, how will you alter your cursor placement and your overall clinical workflow tomorrow? Remember, precision isn't just about taking good images, it's literally the very foundation of safe, evidence-based obstetric care. Thanks so much for joining me for this explainer, and I'll see you on the ward.